Whether you're a parent navigating myofunctional disorders or simply curious about optimizing your family's overall health, the Myohacker podcast is your guide. Hi, I'm Karindy Ong, a speech-language pathologist, myofunctional therapist, and a mom on a mission to bring holistic health to you and your family. Together, we'll explore whole-body connections and integrative solutions. Please subscribe and leave us a 5-star review to help other families discover this important information. Visit myohackerslp.com for free resources and guides. Quick disclaimer. The content shared in this podcast is for information and entertainment purposes only. The views and opinions expressed by the host and guests do not necessarily reflect those of the podcast or its affiliates. This podcast does not provide medical, legal, or professional advice. Always consult a professional regarding your circumstances. By listening, you agree that the host and podcast are not responsible for any actions you may take based on the information provided. Now, let's dive into today's episode. Welcome, everyone, to the Myohacker podcast. With us today, I am delighted to say we have Keller. She is a pediatric pelvic floor therapist. Dr. Caitlin is a pediatric physical therapist with a heart for kids, a mind for physiology, and a passion for helping families break free from the frustrating cycles of toileting challenges. Since earning her doctorate of physical therapy from Springfield College in 2013, Caitlin has dedicated her career to pediatrics. And since 2014, she's been all in on pediatric pelvic health. So I am so delighted to say, welcome, Dr. Caitlin, to the podcast.
I am so excited to be here. I love that we're combining these two worlds together and going to chat about it, and it's going to be great.
Absolutely. So as we were talking before recording, you gave an excellent example of how you often bring patients an awareness of the connection between the jaw, the airway, and the pelvic floor. Walk us through how they're connected and how you share that with patients.
Yeah, it can be really challenging for a family to understand why am I looking at a child's jaw and mouth, because the child's in our clinic for bowel and bladder health, they're constipated, there's something going on related to toileting, and all of a sudden I'm looking at their mouth and their tongue and how they're moving and doing a screen. And I love to simplify it down and bring it to the birth world, because so many of the families that come in, the moms have gone through birth themselves, right? And so they kind of understand. In the birth world, we talk about how if a jaw is relaxed and the mouth and the tongue is relaxed, that helps the baby to descend easier, faster. That adds some efficiency to the birth process sometimes. And so if that connection is there between jaw and mouth relaxation in birth, why might that not also apply to bowel movements and pelvic floor health and toileting? And so that kind of sets us up to talk about why we're talking about the jaw and the mouth. And so that connection is there. There's a lot we could go into that with the physiology behind that, but I don't think we'll have time for that today, but that connection is there. And so our worlds combine in this really cool integrated way.
Yes. And as I was mentioning to Dr. Keller, just yesterday, even I referred a patient as I was looking at, this is a child who's done myofunctional therapy multiple times, has done different really treatments, but there is still, progress that we're seeking. And as I was looking and talking to them, just seeing that sacral tilt, that it's pretty tight, seeing how he's moving, and then mom expressing that there's difficulty with toileting, and that looks like strain. So can you explain that? Like, why should we not be straining and pushing? Why is that not the desired outcome when a kiddo is going to the bathroom?
Yeah, that's a great question. So think about when somebody's sitting on the toilet, whether it's your child or it's you, and you're having difficulty getting things out. If you are grunting and red in the face and your fists are clenched, all of that's happening. What is happening to your body as a whole? Everything is tensing up. And when things tense up, it happens all over your body at the same time. You can isolate it, but in toileting, that doesn't typically happen. And so we want the pelvic floor, a group of muscles that goes around the holes where pee and poo comes out. We want those muscles to relax, to open those holes. And when you're tensing, when you're gripping, when you're straining, when that when that effort is so high in magnitude, oftentimes that pelvic floor contracts with the rest of your body. And when it contracts, it closes those holes. And then there's no room for anything to come out. So you have this outlet dysfunction because nothing can go out through a hole that's closed.
So that totally makes sense. It's like, okay, well then, and just the valve, the pressures of the body, when they are not coordinated and it's imbalanced, it's going to be, there's either too much or too little that's being released as far as just pressures of the body. And that's where I will see it, that I'm not seeing connections in, they're not getting the swallow pressure they want. We might see increased reflux, other types of signs and symptoms that there's oral motor coordination issues. Their swallow isn't as tight and succinct as we want it to be. And you'll see that go all the way down the chain. And that's when I'm like, we actually need pelvic floor therapy on board. But sometimes when I make this referral, moms who have done pelvic floor therapy themselves are like, hang on, I had kiddos, then I did pelvic floor PT. How in the world can you do this with children? Tell us how.
Yeah. So there is a general consensus that in pediatrics, you don't do any kind of internal work. So I'm going to start there. There's no internal work. There might be exceptions with teens and other clinics, but for us, there's no internal work at all.
Mm-hmm.
I would say up to 80% of our work in therapy looks like developmental play and gross motor, high functioning tasks, coordination. And so we're in the hallway skipping, things like that, because when there's a weakness or a discoordination in a muscle group of the body, let's say the hip muscles are weak. When a child, a 6-year-old, wants to go up the stairs, they can go up the stairs, but if they have hip weakness, which is the muscle group that we want to help them go up the stair, if that muscle group is weak, well, how are they still doing it? How are they still getting up the stair if that hip muscle group is weak? They're compensating somewhere else. They're using another group of muscles to get them to be able to do that task, which is great. We want them to be functioning. But then in response to that, that pelvic floor is likely one of those groups that is upregulated and is tight and is habitually working to get them up that stair to provide that force to go up. And so how do we work against that? Because that's a huge contributing factor to constipation, outlet dysfunction, having kind of gut dysregularity or any kind of digestive challenge could be related to chronic, habitual, upregulated pelvic floor muscle tone. And so if we want to offload that and allow some more mobility into the pelvic floor, those muscles, how do we do that? Remove the need for it to be a compensatory group. We remove the need for it to kind of add in because of that weak hip muscle group. So what do? We strengthen the hips, we add in some breath work, and that allows the pelvic floor to relax on a more regular basis because it's not having to take over the role of the hip muscles to get the child up the stairs. Now the hip muscles are getting them up the stairs. And then because of that, that pelvic floor is then able to move on a regular basis and then open and relax and lengthen during toileting more easily because it's not habitually tight. And so from our pediatric perspective, that's kind of our mission, our methodology is we don't want to do internal work on kids like they do in the adult world. And there's a time and a place for it in the adult world. But from the adult perspective too, like, might that also apply to adults? And so we really believe in a whole body approach because if we see strength deficits, if we see tension happening, some jaw jutting, tongue is moving all the time when they're trying to do this skipping task. Well, why are they jutting their head forward, jutting their chin out, cervical retraction, their neck is all tucked, their tongue is moving all the time? What compensations are they doing in their body to try to do this skill? If we can work on the skill, that allows those other groups of muscles to behave habitually in a way that they're meant to instead of chronically being tight.
Wow. It's so interesting too. I think of, when kids see you guys, the developmental issues that are there that sometimes stand out, sometimes they don't, but you can see how pediatric pelvic floor therapy gets them back on track from a developmental standpoint? Because, well, you tell me, why does it do that?
Why does it get them back on track?
Yeah, because, well, I'll just say, I see all of a sudden gait changes, even the feet, sensory issues, they might be sensory seeking. And I'm not saying that all is, taken care of through pelvic floor therapy, but it will be interesting to see they seem to be more grounded. They're more aware of just proprioception seems to increase when you see more of this joint on joint, more coordinated movement, core engagement, and diaphragmatic work for me is so much easier once they've done pelvic floor therapy. So that's what I mean. That's where I see some of these changes developmentally. And it makes sense that if they're not able to move in a way that helps them go to the bathroom, it's affecting movement throughout everything.
Mm-hmm. Yeah. So let me pull you through an example of a skill that I love to work on because it tackles so much all at once. And I think that is why our kids leave therapy with that grounding. They know where their body is in space. So if you're familiar with scissor jumps or switch jumps, one foot kind of moves forward and the other moves back while the upper body stays still in space. And we do what we call layering tasks. We layer some qualities on top of that. So that's our baseline task of like doing the specific jump skill. And then we'll say, hey, do you notice when you're doing that, that your toes are pointed to the side? Could you pretend like there's a flashlight in your big toe and keep your toes pointed straight? So now they're doing the jumping skill and then they're layering that quality, that movement quality on top of that. And then, we don't overburden our kids with different things to think about, especially like when it's really challenging. But then we might say, I hear when you're done, your breath goes, are you maybe holding your breath while you're doing it? So let's get a pinwheel. And every time you jump, you're going to jump, keep your flashlights forward, and you're going to blow the pinwheel on each jump. And then we kind of layer other things. Can you stop on number 7? Can you count backwards from 10? There's this whole, how many things can we help your brain be aware of in your body as you're doing this skill? And yes, a lot of it is physiology. Like we are strengthening the hips in better alignment. Absolutely. We're getting the feet fully in contact with the floor instead of just on the toes. But then we're also layering this proprioceptive, kinesthetic, where is my body in space? Do I know where it is and where am I going next? Because all of that is, can I participate in school? Can I participate in play? Can I be on the playground and also simultaneously be aware of the urges related to toileting? And so we're working on that urge awareness piece. We're working on that strengthening piece to offload the pelvic floor. We're working on the breath pressure management system, kind of all simultaneously. And oh, don't you know, if this is pelvic floor therapy, but we're not on a table doing internal work. And so it's super fun. Kids are engaged and we make progress, and that's the biggest goal, right? So I think this all stemmed from how do we do pelvic floor therapy with kids, but that's
Yeah.
kind of an example of what that might look like.
So, what are some of the common, because you had mentioned there was constipation, and then there was another thing you said. I can't remember what it was. It was a word. I was like, oh, I don't know what that word is. It wasn't withholding, but it was
Maybe
like,
outlet dysfunction.
yes.
Yeah.
So, what are some of the, we can have, okay, constipation, but what are some of the diagnoses, or I don't even know if you want to call it that. Like, what are the issues you see? Take us through that because, maybe someone's listening and they're like, my kid isn't constipated. They're actually going all the time. They don't have a valve to shut off. Like, walk us through that.
Yeah. So starting at birth, babies can be constipated, and there's many reasons why. And we talk about in pediatrics, we talk about tension and how babies can have tension from birth because of various reasons. And sometimes that plays out in symptoms related to reflux, gasiness, colic, but sometimes it's related to digestion and tolerance to food, and maybe they're constipated because, there's a lot of language about how going every 7 days as a breastfed baby is normal, but in the context of how a baby presents, I would like to challenge that might not be normal.
Mm-hmm.
So babies can have challenges related to getting their poop and pee out. You move into toddlerhood and introduction of solids. Sometimes that is kind of the catalyst to constipation or some kind of bowel disruption. Moving into potty training, there's many kids that move through it successfully. But then there's this whole other group of kids and families where
Mm-hmm.
they start implementing a potty training method and things tank. There is now constipation, there is fear, and now all of a sudden you're in this long duration. You're really trying to potty train, and it's taking months and months and months. When in reality, when you start introducing this new skill and you say, okay, let's kind of get rid of the diapers and see what happens, if your child has the foundational physical skills to push poop out and to be able to think about their body, that process should take a week or two and then transition into no leaks, no accidents. And so we see a lot of kids that the potty training process has taken a long time, and parents are kind of trying to figure out why that is. And then we'll kind of look at their skills that they have and see, oh, they skipped crawling and they sit in this really interesting posture and they're still standing to get poop out into their pull up, and their posture is a little bit malaligned. So we can work on all of that. And we see this other influx of kids who are maybe 5, 6, 7, 8 years old, where potty training was challenging. They worked through it, they got it, kind of. There's always been some level of minimal effort. It's not been enough to kind of push a family into going to seek help. And then all of a sudden, there's an explosion of symptoms. We see a lot of those kids in that 5, 6, 7 age group, and then also maybe closer to 10 and 12. And that might look like poop smears in the underwear. That might look like prolonged nighttime bedwetting. That might look like frequency. So they're going to the bathroom all of the time. It might be on the opposite end when they're constipated. There might be some rumination or constant vomiting. There's just a lot that can happen, especially as kids get older, because things get more complex. Those underlying root causes haven't been yet like fully addressed, and that can manifest in so many different ways and cause symptoms that are seemingly unrelated, but then when we dig deeper, they might be. And so, yeah, lots
That's
of
so interesting. So the rumination and vomiting, tell me about, because that comes a little bit into the feeding
Mhm.
arena. Tell me about that connection. I'm super curious.
So we talk about how there are diaphragms of the body, and everyone's
Mm-hmm.
pretty familiar with the diaphragm, the breathing diaphragm, the
Mm-hmm.
muscle that's under the lungs.
Right.
We like to think about in the therapy world that the airway and the pelvic diaphragms also are part of this diaphragm network. So we have a valve at the top, we have a valve at the bottom, and we have the diaphragm in the middle. And so we want those things to work like a valve in synchrony. And so if there's one part of it that is tight, locked up for some reason, has some immobility, then it affects everything else. And so a child might come to us with constipation, but then we find out that they also have some rumination going on. Well, why is that? It's because there's some interconnections between those valves. So we might work on breath work, and that might help both the top and the bottom because you're working on the pressure system that has 3 parts involved, not just this belly diaphragmatic breath diaphragm that we think about.
Right. That was fabulous. Okay.
Thanks.
Yeah. No, I'm like, yes, that was so clear. So tell me about, night or kids that they seem to toilet train fine for the day, but bedwetting at night continues for quite a bit longer.
Mhm.
And I know you see that a lot because I'll be like, you guys need to go. Tell me about that. Like, what is happening? Why is it that they were able to get it down during the day and it's not carrying over at night?
So I'm going to first start with our guideline about what nighttime dryness should be in terms of a timeline. So when a kiddo is dry and clean during the day and going to the bathroom and self-initiating, nighttime dryness should be happening on its own organically without any purposeful effort within the next 6 months. So that means if you potty train your 2.5-year-old, that by 3, they should be dry at night. That's because they're solidifying their brain body connection of urge awareness, responding to that, and then also developmentally getting into that withholding or holding pattern with their bladder. There's storage and then there's emptying. Then it's fully storing and then it's fully emptying. We see disruption to this nighttime dryness pattern often, and I'm going to generalize, there's
Yep.
absolutely exceptions and other
Yeah.
things that can happen. But one big factor that we see is the potty training process is driven by rewards, which can be a positive thing for many kids. But if a child is so motivated to get that M&M or the sticker or whatever the reward is, and they say, look, I went potty, there's 3 drips of pee in the potty. Okay, did you respond to an urge, or are you just pushing pee out to get that M&M? And that's kind of a simplified version. There's lots of different ways that it can look. Lots of prompting can add to this too, like going to the bathroom every 45 minutes just in case, hey, it's been 45 minutes, let's go try. Because what's happening is the child is, number one, learning that they can toilet in response to no urge at all. You know, we want that to happen if we're going to go on a long car ride, but we don't want that to be a majority of the time. And then they're forcing things out through their pelvic floor, maybe not fully relaxing. They don't have an urge, they're rushing, they're excited. If there's not an emphasis of like respond, sit, relax, and then you empty, if the intention and motivation is get the reward, then there might be this process of I don't really need to go, but I want to. The pelvic floor isn't relaxing, but you're still forcing urine and stool through that tight, non-relaxed pelvic floor. That's confusing to the brain and the body because that's not supposed to happen. The brain has a really big job in understanding and being aware of, oh, we're sitting, we're ready to go. And then the brain does a couple of things that we can't control. So the brain is the one that controls the contraction of the bladder. That's not a muscle that we can contract. The bladder is like this big balloon made of muscle, and it kind of squeezes, and that's what helps the pee empty out. When we're just using our belly pressure to push pee out, we're telling our brain, hey, hold on, you don't have to do anything. Don't worry about emptying the bladder. We got it,
Oh,
right?
this is so good.
And
Okay.
it introduces this confusion. So then in the future, when you do have an urge and you do sit because you feel pee ready to come out, the brain is like, well, wait a minute. Like, I thought I was out of the job. I don't need to help the bladder contract because you have it, right? And
Hmm.
so then there's retention and overflow and leakage. And that whole disruption of the neurological system related to toileting is then what compounds on nighttime wetting because you're unconscious. Like, how are you going to add in a level of control over letting pee out if you're asleep? You can't. During the day, you might be able to. During the day, you know, a lot of these kids that are so motivated by the rewards are maybe like, I'm going to generalize again, but like wanting to be pleasing to the adults or people that they're with. And so if they're in school, they're going to do everything that they can to try to like hold that pee in. They are further disrupting that system.
Hmm. Wow.
Everything's already confused, but then they also don't want to leak anymore. They're being told they shouldn't be leaking anymore. There's a suppression of urges because that's what kids think, right? If I don't want to leak in my underwear, I'm just going to hold it in. And then what does that further do to the pelvic floor and the tension that might be there? So it's this whole snowball effect that typically, again, I'm generalizing, starts in potty training. There's this motivation factor. They're not listening to their body. They kind of get potty training and they're dry during the day, but that nighttime piece never kicks in because their neurological system is so confused. And then at some point, there's either a family member who says, like, hey, you're 9 years old, let's work on this nighttime wedding thing. Or it snowballs even further. And now there's poop leaks, pee leaks during the day, constipation, other symptoms that can arise because those symptoms have lasted so long. The system is so confused.
Hmm.
Functioning in a healthy way becomes really challenging.
So what on earth would like therapy look like? I'm just thinking like, whoa, let's say a 9-year-old. I can picture it more for like little ones. Let's say an older kiddo. What does that look like when they come in? And and you're so wonderful at handling these things delicately, but also like there's no shame in this. We're talking about this with kids. What would that look like?
Yeah, that's a good question. The biggest piece that I love to bring in to every session is we are helping, and I'm talking to the child now, we are helping you teach your body how to do this skill. And that removes the blame shame game that is sometimes played. Like, you are pooping in your underwear and you are still peeing in nighttime bedwetting. Instead, we changed the language. We put everybody on the same team, right? Like me, the family, the kiddo. We are going to help you teach your body how to do this in a different way. And that can be a really great positive start to like a 12-year-old boy, right? Who's in clinic with me, a woman, like that is as different as you can be. And
Mm-hmm.
talking about toileting, and that's embarrassing. And so thinking about it in an autonomy perspective, this is your body. It's a skill. We're going to teach your body to do this skill in a different way. That's the biggest starting point that I love to emphasize. And then from there, we just kind of like look at their presentation. What are they doing on a regular
Yeah.
base that might be an extra hurdle to healthy toileting? You know, are you pushing pee out? Are you going when you need to go? Are you withholding and not, you know, you need to go to the bathroom, but you're not going? Can you skip? Can you do jumping jacks? What does your ability to stand up from the floor look like? What does your habitual posture at school look like, or while you're sitting all day, or when you're playing with your siblings? What does that look like? So we start with the language, and then we look at everyday tasks, and then we kind of further break it down from there.
So we just talked about older ages. It makes me, as I'm like picturing, a 12-year-old, I'm thinking, okay, we're going back and looking at crawling history and developmental history. Tell me about the importance of crawling in regards to pelvic floor, neurological development,
Yeah. So let's see, where do we want to start?
right?
So crawling does a couple of things. Crawling, think of hands and knees, belly off the floor, and not the army crawling, right? Belly off the floor, left hand, right hand, reciprocal movement pattern. That does a lot. That helps to strengthen the body and the core in ways that maybe an infant and early toddlerhood gets a lot of strengthening, right? We want that strength there through the core. It gets equal mobility through hips. When we think about like asymmetrical crawling, sometimes people call it janky crawling. Sometimes people think of like one foot's propped up and their bum scooting on one side. That's adding a lot of asymmetry to the trunk, the back, and the pelvis. And what does that do then to the pelvic floor? It's this whole round diaphragm that is then torqued. There is
Wow.
some rotation. And so when we want the pelvic floor to come up and then relax back down to let things out, if it's torqued, it's going to function in a completely different way. Even if you're sitting symmetrically on the toilet, if it's so used to being rotated in one direction, it's going to stay tight on that one side.
Hmm.
So crawling adds in some balance and movement and hip mobility. And then the third big thing that I think that it does is it helps to integrate primitive reflexes.
Yes.
Yeah, so primitive reflexes are these things that our body is born with. I like to call them survival mechanisms. They're ways that our body kind of reflexively acts and behaves because this reflex is there. So you stroke a baby's cheek, they turn towards the milk. That's a survival skill, but then it also adds in movement and they learn how to move their body. We love that. We love those reflexes to help an infant and early toddler to help move their body. We don't want them to stay there forever because if I stroke a 9-year-old's cheek, I don't want him to turn towards my finger. I want him to have autonomy and independent movement over his body.
Yeah.
There's lots of different reflexes. We typically screen for 5 in our clinic. But if your child is moving their body in response to reflexes, and those reflexes haven't what we call integrated, means they're no longer dominating how you're able to move your body, well, that's going to impair your ability to coordinate your body to move in a specific way, to be able to feel your body, to be able to be aware of your body and do different skills because your body is saying, well, you want to move that way, but you're doing this, so now reflexively we have to do it this way.
Hmm.
And that is very limiting to a body when we're trying to help them achieve different skills.
Okay. I specifically had a question from a mom. She was like, because I recommended pelvic floor therapy. She was like, well, I think primitive reflexes are at play here. Do they address that? So take us through, just tell us which 5 you screen for. I'm going to send her this specifically and be like, listen, right here.
Okay. So let's see. In our clinic at Unconstipated Kids, we screen for ATNR, the asymmetrical neck tonic reflex, which looks at when we turn your head one way, what do your arms and your lower body do? We look at STNR, which is the same thing, but in a different direction. We look at spinal galant, which is down the spine. We look at TLR, which is like on the belly, front, back kind of movement, and Moro, which is the biggest one. We see Moro be retained a lot. Moro is typically connected to like big emotions that are hard to come back down, but it also can be in control of other things in your body related to coordination and movement. Yeah. So
I'm going to send it and say, there, that's the rundown. These are the primitive reflexes. Now, the thing is, those are the 5 that you're screening for and targeting, like addressing. But when you're moving the body better, like when you are having more coordinated movements, things can start to integrate that you're not even like testing for. So there are far reaching impacts of this kind of therapy that we won't even cover today, but we could. Something I do want to talk about is the vagus nerve and pelvic floor therapy, like the autonomic nervous system. That's your fight or flight, you relax, all of that. I mean, again, I'd mentioned before, like diaphragmatic breathing is so different for kids. Like it's just easier for me to target when they've done pelvic floor therapy. So if you could talk about that, like, do you specifically target the vagus nerve or is it just indirect?
it's indirect. Yeah.
Wow.
So there's a lot of space to kind of purposefully look at it,
Mm-hmm.
but many of the things that we do kind of just trickle down into some organic, improvement of vagal nerve stimulation,
Mm-hmm.
parasympathetic work, because we're working on mobility through the belly, rotation through the belly and the rib cage.
Mm.
We're looking at breath work, right? That pressure system that we talked about before, because that's so key for pelvic floor mobility. We want those muscles to contract and relax. Breathing helps to stimulate that. We talk about intermittent breath pauses throughout the day. So thinking about helping the child to say, what is my pelvic floor doing right now? Am I tight and turned on and squeezed up? Am I relaxed or am I bearing down and pushing? And so oftentimes kids are upregulated, habitually tight. And so when we introduce this, hey, every time you change classrooms, every time you eat a meal, before you do that, sit and think, what is, and I'm going to say the words that I use in clinic because we talk about the anatomy, right? Is your anus pulled up and in, relaxed, or pushing down? Because that gives the child something to think about, to know specifically. When we add specificity, it adds this layer of accessibility to them, right? You can't see your pelvic floor muscles, but they know where their anus is. They know
Yes.
the poop leads through that, right? They know that. And so that gives them a tangible thing to think about. And when we add in that intermittent breath work throughout the day, what is that then doing to vagal nerve health? A lot. The rib mobility that we do, a lot. We do a lot of cervical range of motion. Kiddos have a history of torticollis as a baby. They may or may not have used a helmet. Maybe they're seeing a myofunctional therapist. Maybe they have pocketing of food when they're eating or gagging on things when the parent is like, why are you gagging on a cracker? Right? And we talk about movement through the shoulders and the scapula. We do a lot in quadruped, which is a crawling position. And so, can they crawl forwards and backwards? And how much of that allows structurally the vagal nerve to work in the way that it's supposed to?
Okay. I love that you're doing, I mean, it makes sense. You guys are doing quadruped, but I just will use that quite a bit in therapy. Like I'll be like, okay, their tongue can do these things when they're seated upright, but let's change gravity a little bit and get them down. And then, okay, now you're looking down. Now bring your head up. Let's change that positioning. And that's where I'll start to see those compensations hit, usually throughout like the abdomen, the pelvic floor, even just how their feet are oriented. And so that was just a side note, but I was like, oh, I get excited that you're doing the quadruped. Tell me why, this is a side note. Again, I love these with you. You use the specific anatomy names I think it's so important for people to hear that because they might be uncomfortable. They might be like, oh my gosh, I do not want my little girl saying anus.
Mhm.
We need to know. Well, you share. What?
Yeah, so there is one study, and I will send it to you. A study that talks about how, this is a heavy topic, but kids that are sexually abused tend to not know their anatomy, and then they don't have the language to talk to their parents. And that's what a predator looks for. A predator looks for somebody who's disconnected from their family and then doesn't have the language and doesn't have the communication or relationship there. And so I want to give families the ability to talk about this in a way that's really specific and clear because number one, we're talking about sensitive things in clinic, and I want to make sure that everyone's protected here and safe. And then I want to be able to say, now, when you go into the real world, these are the areas of your body that are safe and private to you. And if that is not something that's happening, here's the language to talk about your body part instead of these convoluted words that sometimes mean something, but there's no
Yeah.
clarity there.
Yeah.
So that's one big reason. The other big reason that we use actual anatomical language is because, like I said before, we want to give kids a tangible thing instead of just saying, like, for example, go do a push-up. If I say, put your hands on the floor flat, and then I want you to straighten your elbows. Well, how much more clear is that? Like that's an instruction that's easier to follow. So if I say push down like you're trying to poop, but they have all of these dysfunctional mechanics, well, they're going to push down how they think to push down. But what is really happening? Are they tightening in response to that? Are they gripping? Are they tensing everywhere through their body? Yeah, because that's what they know. So I'm saying push down. I'm wanting their pelvic floor to lengthen and open. But really what's happening is they're doing the opposite because they don't know what push down is. So when I say move your anus closer to the floor, push your anus down towards your feet, that's a really clear, specific instruction that's so much easier to follow.
Yes.
Yeah.
I'm laughing. I'll have to send you a picture later of we have a checklist in the bathroom
Mhm.
for my boys, and on it says wash your anus. And I'm like, I'm not taking it down. If you come over to my house and you wash your hands, you will see it.
I love
It's
that.
amazing. But so I'm a fan of using the anatomy specific terms for sure.
Mm-hmm.
Okay, so someone's listening and they're like, I am listening to this because my child has airway concerns. What are the times that you have a patient that comes in and you refer to an airway provider? Like, what are sort of the signs and symptoms that you're looking out for, red flags that people should be aware of, that this is related to pelvic floor? Because I think they'll then be able to be like, oh, and realize the connection of why they need you.
So if we're seeing somebody in clinic, we do a screen that I sent to you a long time ago and you kind of blessed, right? You said, yep, this is a good screen. Start here. So we're looking at, when a patient closes their mouth, is there crossbite happening? Are their top teeth over their bottom teeth like we want them to be? Are they able to close their mouth and purse their lips over a straw to blow a pom pom? What does their opening look like of their mouth, as wide as it can go? And then can they repeat that opening with their tongue up at the roof of their mouth? What does that opening look like? Can they click their tongue? Can they move their tongue in circles? And so that's kind of our brief screen that we do in clinic. If we see, ooh, there is a lot to work on. This is our first session. Parents are a little overwhelmed. I did not realize that we were going to work on skipping and belly stuff. And oh my goodness, there's a lot here. What I tend to say is, we're going to prioritize a couple of things that we have for toileting health. Continue to practice the airway screen. That is going to help on its own, just to
Yeah.
repeat what we screen for in clinic. And then as we progress, if we see things that are still lingering, if we hit a plateau, if we're not making the progress that we thought, let's go to myofunctional therapy. If there is a huge concern for safety, the ability to chew and swallow, articulation is another big indicator of that, like there's some discoordination of the tongue and the mouth. Maybe instead of speech and articulation, maybe we should pursue myofunctional therapy. So there's a lot of conversation about, like, from the family's perspective too, like, how do we prioritize? There's
For sure.
not an endless amount of time or money.
Right.
And so how are we going to best tackle this? And I think that's the beautiful thing about providers and, locally to us, you and I are local to each other. There is a lot of camaraderie and referring to other people because there is an awareness, there needs to be an awareness globally of this child needs me, but maybe they don't need me right now. Maybe they need somebody else first. Maybe I see a child who can run, skip, jump, they can sit up from the floor, and they also have a lot of challenges related to the airway screen that we just went through. Let's talk about that. There are some things that we can fine tune from a pelvic floor perspective, but your priority is
Yeah.
myofunctional therapy.
So, one issue that comes up a lot is expansion. Someone's going through the process of it, which I'll have you touch on a little later. But, someone's going through that and they're like, they were not having issues with toileting. We've started expansion. Now all of a sudden bedwetting, or they were bedwetting, but now it's a lot, or we're having like just changes in bowel behaviors that can be an issue. I want to hear your perspective on like what is going on? Why are we getting that?
So, especially if there was something already happening, but the quantity or the magnitude was small, and now expansion has led to an increase of magnitude with that, that tells me that there's some underlying root that's in the body, and there's two areas that are being affected, right? So, there's tension and structural challenges related to the mouth, and also there is some toileting dysfunction. And so as we assist with one, maybe there's some compensatory traveling of tension through the body in response to that. So that's not surprising to hear at all if it's already present. Now, sometimes families might think like, oh, they were fine. They didn't have anything related to bowel and bladder. Well, sometimes I might challenge that. Like, skid marks in the underwear might not be hygiene related. It might be leak related, and there might be some incontinence happening. So,
Real quick, how would someone know the difference?
that's a good question. I think it's related to quantity. So, what is the volume there? It's related to when it's happening. If it's happening after a bowel movement and the underwear was clean after hygiene, and then there's the leak happening, then that incontinence is probably incontinence and not hygiene. Inconsistencies, variability, that's another thing related to hygiene. So, if they're struggling to completely and cleanly wipe their bottom, they should be clean all the time. If there's skid marks in the underwear happening some of the time, but not all of the time, that's probably incontinence.
So good to have that clarification. So you're seeing that tension pattern. We're talking about expansion. You're seeing the tension pattern. It might migrate. It might move throughout the body. And that is something. What about the neurological signaling? Like, do you see shifts that you're like, oh, because I'll just say something I see, especially as we get a little bit older, that kids can have that center of gravity kind of shifting on them, especially girls. As they get older, it goes lower. And when we add in expansion, which I'm not saying we don't, it's just be aware that these are factors that play into each other, that we can suddenly have some balance issues, more pelvic floor concerns. Often it will I'll say often in what I've seen, it will kind of resolve within about 4 weeks. But if it doesn't, that's when I'm like, oh, tell me, am I waiting too long to refer if 4 weeks is okay?
I don't
I'm
think
like,
so.
you can tell me.
Nope.
Because we'll see, all right, they sort of got the hang of it. But if they don't, this is more the older kiddos, then I'll be like, all right, please go on in.
Yeah. And 4 weeks is not going to combat 9 years of a root that isn't being addressed yet. So there's a really good chance that as expansion happens or some kind of myofunctional intervention is happening, that there are other changes that happen in the body, right? Like that's our body is all connected. And so when you make a change, there's going to be some domino effects somewhere else. But yeah, if it's increasing the magnitude of symptoms, maybe we need some other additional intervention on board to help with that, because there might be something that's just going to snowball in that direction.
I'll say for the, I don't know that I'll say for the most part, but in many cases, it is tension, specifically on one side. And we're almost in this like ipsilateral movement and the other side sticking, which is why I love to utilize fascia work, which is a perfect little springboard to the fact that, okay, guys, I'm so excited because Dr. Keller is going to be taking CFT, craniosacral fascia therapy, this fall to utilize even more. You already do a lot of things for fascia, but just even more specifically to help with that coordination and bringing across midline that, okay, we can release tension everywhere. And I just love that. Why'd you guys sign up?
So it's been on my list for a while. We're in a good place right now in terms of time and availability to go. And we have myself and another physical therapist and an occupational therapist on our team. And so we are all going together, which I'm very excited about. Our
Yes.
OT has wanted to go. I do want to give her a shout out because we talked a lot about the vagus nerve and primitive reflexes, and she's added so much depth to
Hmm.
those areas in our clinic. And so I'm just excited for all of us to go and pursue that. It's going to be great. I'm really excited about it.
I'm just thrilled because I know people reach out all the time looking for more CFT providers. And it's just, it layers in so beautifully with anyone who's doing body work. When you have awareness of just the fascia and strain patterns and movement patterns, you bring that all together and it's wonderful.
Yeah.
So I do want to ask, what prompted you to do your own expansion journey? Tell us about that. I love that you have, but tell
Yeah.
us about it.
So let's see. I had thought about it for a couple of years. I had 100% crossbite through my mouth, and my dentist continued to tell me that, eventually I was going to need veneers because my teeth were wearing down because of that pattern, and expansion was the way out. So either I could stay with what I was doing and get veneers changed out every 10 years for the rest of my life,
Fun.
or we could expand my palate and get the teeth where they are supposed to be in my mouth. Yeah, and so I got my expander 7 months ago or 6 months ago put in. As an adult, it's screwed into the roof of your mouth, so I have 6 screws with my expander because
Because you have a Marpy, right?
I have a Marpy.
Yeah.
Yep, the suture line is closed as an adult, so they need more leverage, right, to open it back up. So my Marpy's been in since January. We did expansion for about 8 weeks. And then now I'm in the braces stage to kind of realign everything. So I've got a lot of metal in my mouth. I think, it's interesting retrospectively thinking back. My first child was born via cesarean, but it was an attempted home birth. And so after 72 hours of being in labor at home, I was still coping well. I was fine, but fetal heart tones got down to the 60s all of a sudden, and I was still only at 6 centimeters. And so I was emergently transferred and we went to the OR. And so after that, I did a lot of work. I took a coccydynia course for pelvic floor work for pulling it into my work, but also for myself
Yeah.
because I had this thought that maybe my tailbone was hyperflexed. It is. I come to
Wait,
find out that,
share what that means.
yeah,
What does that mean?
there's just a lot of curvature with my tailbone. So everybody's goes in to some degree, but mine is a little bit more than the normal range. And so might that have played into my baby not being able to descend? I also found out after that, I do have a lot of upregulated tight pelvic floor musculature. And might that be related to my palate and airway? I kind of think so because
Yeah. Oh, yeah.
I'm a pelvic floor therapist, right? I know how to relax my pelvic floor. And so, in preparation for my first home birth, I was like, oh, I got this. Like, this is going to be great. And so, I did some pelvic floor work really intensely in preparation for my second birth. And I had 2 successful home births after that. So I have 3 kids. The first is cesarean. The second and the third are home births. And so I think that preparation through pelvic floor therapy and the intensity that I did it was probably why I was successful. But might my palate and the airway be an additional hurdle in limiting my ability to have a vaginal birth that first time. So I had to work really hard to overcome it. If the palate challenges and issues and narrow palate wasn't there, could I have just like been a layperson, not a pelvic floor therapist, and had a vaginal birth? Probably not. And that probably would have been the same for the next two. So you remove the hurdles, you make the task more accessible. You can
Exactly.
have success. The more hurdles you have, the more challenging it is going to be to get the outcome that you want. So the palate was probably just one extra hurdle that I had that first birth. I still had it the second and the third round, but you work on other things, and I think that's what helped me be successful. I hope that makes sense. That was
It does. And I got to say, your cheekbones look killer.
thanks.
It's amazing. It's amazing. So, what are going to be, if you're like, I want parents to walk away with one important just point to know about pelvic floor therapy in children, what would that be?
I love that question. I just want families to know that we exist.
Right?
You know,
Yeah.
there's not a lot of us. Pediatric pelvic floor therapy is few and far between, but we are out there.
Okay, wait. How do people find pediatric pelvic floor therapists?
That's another big problem is there is a network, but it's really just accessible to providers. So yeah, there's some challenge to helping people find a pelvic floor therapist near them. So we always respond, we access that network list when somebody asks us, hey, do you know somebody in Seattle, Washington, or the Netherlands? I can look on that list and get back to them and let them know. Unfortunately, it's often no.
Yeah.
We're there, but that's why, I think you were gonna talk about like how people could access me, but like that's
Yes.
one of the reasons why Dr. Melissa Howard is another pediatric pelvic health therapist in Houston, Texas, and we have been working together for a while now. We have one CEU approved course for providers to take about pediatric pelvic health from a holistic lens, a whole body lens. And then we're also working really hard on parent resources, and we have a potty training guide coming out. We have some nighttime bedwetting resources. So we're really trying to give people accessibility when there's not somebody near them. So her and I each have our own brick and mortar therapy locations in Houston, Texas, where you can get in-person therapy. We both do out of state, out of town intensives. You can come to us for 3, 4, 5 days if you'd like, and we can do like a whole intensive. But sometimes that's not feasible for a family. And so that's why we're also working on this online resource hub, if you will.
Yeah.
So that's through Little Learning Lab, LAV, as in laboratory.
I had wondered, I was like, like love. I don't know. I was trying to figure out what that, got it,
Yeah,
lavatory.
Little Learning Laboratory. And so I'm at Unconstipated Kids for Therapy. She's at Bloom for All PT in Houston. And then together we have Little Learning Lab.
I love that. So I will have all of that in the show notes. Melissa, you're going to be tagged as well. How can we get more pediatric pelvic floor therapists, and how it's so inaccessible in different locations for families? I didn't know this, but Caitlin at Unconstipated Kids, does Melissa as well?
Yes. Mm-hmm.
Okay. They both offer coaching. So what that means, this is not therapy because we cross state lines, things get weird, but it is parent coaching on, well, you tell, what is it?
Yeah, so we talk to you, the parent, the family member, about like what's going on, what's going on with your child and their symptoms that they're having. And then we talk about what you've done to help them. We kind of talk about how they function on a day-to-day basis. We give some knowledge to the parent, like you are going to act like an investigator. Look at how they're sitting, look at how they're breathing, look at how they're moving, and just kind of think about it from the perspective of, is there balance in their body? Do they always have one foot tucked underneath their bottom? If they do, I can guarantee you that that's affecting their pelvic floor. So a lot of just like verbal guidance with the family, and kind of guide you through success through the computer screen, which is wild that
Which is
that can happen.
wonderful.
But yeah, we get there. So
Wow.
It's definitely feasible. Sometimes it can be harder depending on the situation, but some kind of care is better than no care, right? If you're kind of stuck in the
Absolutely.
middle of somewhere with nothing. So we are doing our best to continue to reach the people that need help no matter where you are.
So if you're like, there's not one near me, we have a solution. You can reach out and you can get that coaching via the computer. So this has just been such an in-depth, wonderful podcast. I cannot wait to I'm going to spam people with it. I'm going to be like, I need you to listen to minute 35 or whatever it is. It's so wonderful that you took the time and shared this. So guys, please go follow Unconstipated Kids, Little Learning Lab. These are great resources. And just Caitlin has just been so generous with her time, and she's generous with her knowledge, which I just greatly, greatly appreciate. So everyone, thank you for listening to the Myohacker podcast. You know the drill. Please like, share, get the word out about the podcast. It also really helps if you can rate and review the podcast 5 stars. If you didn't like it, please don't rate and review. But we would love to get more just eyes and ears on this information, because like Caitlin was saying, there are lots of places where there are not pelvic floor therapists, and it might be that the PTs just don't even know about it. They might not realize they can specialize in this. And it's so often that there's a therapist who has a pain point. For me, that's why I got into airway stuff, was because of my own children. It might be there's a PT out there and she's like, oh my gosh, my kiddos are having these issues. And just hearing about this and seeing like I can get into that in this beautiful way that Caitlin described, you might inspire a therapist near you. So everyone, thank you for your time. I look forward to seeing you all next week. I hope you have enjoyed this episode of the Myohacker podcast. Remember, small changes can make big impacts on our overall health and well-being. If you enjoyed this episode, please take a moment to rate and review wherever you get your podcasts. This way, more families will learn about this important information and we can make a bigger impact. Head on over to myohackerslp.com for in-depth resources and guides. You can also join me on Instagram at myohackerslp for bonus content and demos. And if you have questions or topic suggestions for future episodes, send me a message. I would love to hear from you. Until next time, let's biohack myofunctional health as myohackers who change the world through intentional action and connection and breathing. Quick disclaimer reminder, the content shared in this podcast is for informational and entertainment purposes only.